Omar's going mobile. Hello, Lorraine.
Good afternoon, Withal.
Okay, well, welcome, ladies and gentlemen, to this, the George Eliot September Board. We've having a few technical difficulties, so some colleagues will be joining later. But just by way of introduction, I just wanted to say a few words. The first was an enormous thank you to every one of our frontline teams who have been putting in phenomenal efforts generally, but particularly during the strike actions that has been occurring. I know the practical difficulties that the strike actions cause for our patients and their families, and those members of staff who support with even extra efforts during that time. It's extremely appreciated by all the board. The second is there's been a lot of things in the press recently. I just wanted to shout out my thanks, and I know the thanks of all the board, to our maternity and midwifery teams who day in, day out ensure that babies are delivered safely in North Warwickshire. They do a phenomenal amount of work. I can't say how proud I am of them, and that they have all of the board's full support during these challenging times. The third thing I wanted to mention was this is the first time we've met as a George Eliot board with our new Chief Medical Officer. So a big shout out to Naj. As I said earlier, Naj, I couldn't be more pleased that you were appointed. You've already had a phenomenal impact since you joined George Eliot, and I'm sure you'll take us to the next level. And on the subject of the next level, I'm sure Catherine will mention it later, but I wanted to say how proud I am as chair that George Eliot is now on the standard operating framework, a level 2 acute provider. Swift is a level 1 acute provider. George Eliot now a level 2. The other acute provider in our system is a level 3 provider, and the system is now a level 2 provider as well. But the tough decisions we made as a board earlier on, particularly around ENT, were instrumental in driving our performance to allow us to achieve that. So well done, everyone. Fifth point of introduction is to our 3 new associate NEDs. I'm absolutely delighted that Jackie, Mark and Paul are with us today. We hope you enjoy the journey of being a associate NED with us. Your skills and expertise will add an enormous amount to what we talk about and decide as a board, so welcome. And finally, the foundation group has expanded since we last met and is now a gang of 4 with Worcester Acute joining us. We have found, since we joined as George Eliot, the foundation group, enormous benefits in terms of shared learning and experience to help us drive our own improvement programme. And I'm sure the arrival of Worcester Acute will add to that rich brew of talent across the 4 different trusts, which will help us at George Eliot achieve even more. So with those words of introduction, we have apologies for absence from Gertie. So Sarah, it's nice to see you again with us. Any new declarations of interest? Could you please raise a digital hand? Glenn?
So Russell, as you mentioned, I should formally record the fact that I'm Chief Executive of Worcester Acute Hospitals now that they've joined the group.
And can I similarly declare that I am now Chairman of Worcester Acute? Hack?
Yeah, I've got a couple. Director of a company called Designs and Build, and my son is working in the information department.
Okay, thank you, Hack. And Sarah?
I've become a trustee at the Central England Law Centre. I've added it, but I don't think it's appeared yet. Okay,
so if you need legal advice, Sarah's another go-to person. Okay, thank you very much for that. And Paul?
Just to say, occasionally I work in a consultancy capacity with various NHS customers across the West Midlands.
Okay, thank you very much, Paul. So we'll then move on with those points all noted. Thank you, Sarah Collette. To the minutes of the public board meeting held on the 19th of June, which is an extraordinary board, and the 4th of July. Any questions or points of accuracy which colleagues would like to point out on those? Please raise a digital hand. Okay, can't see any digital hands raised, so I'll take those as accurate. So we'll then move on to the action points arising from those. The first was for Jenny to provide an update on the use of eco solar panels and energy efficient windows in the next quarterly sustainability report. We have partly discussed that at a workshop this morning, but it will come back formally to the public board in October. Thank you, Jenny. And then had to discuss proposal for an independent review of the BAF and corporate register with the audit committee. That was done. Thank you, Hack. On sustainability risk, that will again come back to us in October, but like I just said, we have discussed that. The CQC inspection report of urgent and emergency care to be brought back. That's on the agenda for later, so thank you. Maternity assurance report, that's on today's board, and Lorraine, it's lovely to see you with us. Then nudge to check that patients with a mental health learning disability diagnosis was routinely flagged. Nudge, do you just want to update us on this?
Yes, thanks, Chair. So the question was, are patients with mental health and learning disability flagged in terms of clinical prioritisation? So in terms of clinical prioritisation, it depends on what their clinical needs are. So that's as per national guidance. However, they are flagged from their mental health and learning disability point of view for us to make their admission a smoother process. So, for example, the teams can arrange transport. We can alert our learning disability nursing teams. We can provide carer support throughout their stay. So we do make sure that it is flagged and make arrangements to make, as I say, their admission process as smooth as possible.
Thank you very much, Nudge. And we were talking earlier about passports in that regard. And then on Health Watch to be routinely invited, that's included for the plan, so that was done. Thank you. Then Hack to look at whether the trust received frequent FOIs. You did respond to me, Hack, so thank you for doing that. And then Jenny to consider using a more positive and appropriate title for the Warwickshire North Levelling Up Report. And that's now described as the Warwickshire North Impact Report. So thank you for doing that, Jenny. Are there any matters arising the colleagues feel I've missed? Okay, so our last board meeting, members of the public may recall, was at the beginning of August, which was a 3-board foundation group meeting. And so we have the minutes of that. If there are any points of accuracy on that, could you please raise a digital hand? Okay, so I think that's all kosher, so to speak. So we then move to the action points arising. Just bear with me. And there were a few. The first was for the MDs to ensure an analysis takes place to compare cancer diagnoses from ED attendance across each trust. Catherine, that's in hand.
I believe so, yes, Russell.
Okay, super. Thank you very much. I do think it's very important just to mention in terms of our cancer performance, the effective working with our tertiary partners is going to become absolutely key if we're going to be able to minimise cancer rates for the citizens we serve. So as a board, just to give members of the public some assurance, we are very focused on ensuring all aspects of the pathway are as efficient as they can be. And then there was a deep dive into additional performance measures in terms of theatre productivity, and that work's ongoing, isn't it, Robin?
Yes, that's correct, Chair.
Super, thank you. So the actions arising out of the foundation group 3-board meeting the colleagues feel I've missed, please raise a digital hand. Okie dokie, we'll move on then. And the first up on the strategic section of the agenda is Glenn's Chief Executive Report. So Glenn, over to you.
Thank you, Chairman. You've already led on my best story, which is the segmentation result. Just to formally record the fact that that is due to sustained improvement on a range of indicators, obviously including our CQC inspection around urgent emergency care, but also some of the other KPIs that we'll be looking at as part of the performance dashboard. As you say, elsewhere in the system, we've got SWIFT in segment 1, UHW in segment 3, Common Financial Partnership Trust in segment 3. So as a system overall, we've moved to segment 2 on the back of the improvement at George Eliot. So that's really good to see. It's all about sustaining it, of course, and it will be a challenging few months ahead, and we'll obviously look at some of the performance data on that later. There's then quite a lot of content elsewhere in my report, and I tried to summarise this as best I can. One of the first things I talk about there is the urgent emergency care summit that took place a couple of months ago now, which I was invited to. It's a really good stock take following the summit that we had in January, to look at the progress that we need to make, particularly getting people into the mindset where to manage urgent emergency care, that focus on particularly frail older people and managing their entire pathway in and out of hospital, which was really focused on, and improvements such as those that we've seen locally in same-day emergency care, really optimising the use of beds in the NHS and only admitting patients into beds when we absolutely need to and getting them back home as quickly as possible. Overall, from an elective recovery perspective, the system position has improved, although this report went out when I was on leave, and it refers to the regional passion, which I've never noticed the region have. So it should be regional position in that paragraph, just to be clear. Winter planning, good to see for the first time ever a winter letter that got out before winter. So end of July was the planning letter on that, and I've included a full extract from the letter, which talks about the things that need to be in place from a community and an acute perspective, which is a really useful checklist, which I know that we've been using in order to frame our response to this winter. We're really lucky that we do have something up our sleeve this winter with the additional beds coming on stream around Christmas time. And that will be really key for us to ensure that, particularly in that final quarter of the year, that we manage the pressures that we will undoubtedly face. I also flagged there the capital incentive that's been introduced this year, and I think we should consider ourselves in a good place to go for that as an organisation. Quite a big capital pot that might be spread between quite a small number of organisations based on the performance data I'm seeing at the moment. So that would be a great prize for us to focus on. So we will look at our progress against that as we go through the year. There's then some content on the NHS workforce plan. I also then sadly have to refer to the conviction of Lucy Letby, which was an absolutely sickening case. I know we will look at the implications of that locally. That obviously the NHS is looking at the implications of that. Personally, I think it's really important that we don't just look at this from a neonatal perspective, that we consider that you could have someone like that, sadly, working in any part of the NHS, and we need to be really quick at spotting that and preventing that where we can and dealing with those issues if they come forward. So there'll be ongoing learning from that, and Catherine actually is going to a session, a national session for me this week, and I no doubt we'll bring that back as soon as we can. Changes to the fit and proper person test that I referred to, thanks to Sarah for pulling that together. And then an update from our surgery directorate. Quite a lot of change going on in there. Also, what's referenced here actually is the change to the ENT service arrangements, the collaboration between George Eliot and Swift, which is one of the things that's helped us to get ourselves into segment 2, which, as you suggested, Chairman, wasn't an easy decision to make, but has certainly benefited our patients. And we will be moving, which is a really important move as part of that, to introduce day case surgery in George Eliot for ENT patients, which is a really important element of local access. And then there's an update from the Allied Health Professionals innovation, which is really worth a read. And then the usual list of of visits to departments from chief officers, and non-execs are attending those too. So I'm happy to take any questions on any of that or anything else.
No, thank you very much, Glenn. Any questions or perspectives to Glenn? Julie?
Thanks very much, Chair. Thanks, Glenn. As always, a really full report. There's just a couple of things. On the incentive for performance achievement, just to understand why that's capital, given that it's a revenue type expenditure is the first one. And also in the workforce plan, I'm not aware of this, but is there anything in there, given the ongoing industrial action being taken around review of pay grades, that might help us going forward?
Okay, so I'll deal with your first question first. I'll take any incentive, Julie, if we can achieve it. And I think it's fair to say the way that they've structured this one is to, because it's a performance indicator at the very end of a financial year, if they made it a revenue incentive, that would be lost in the end point of any individual organisation. So capital availability in the following year is something that we can actually do something with. So I support it for that reason. As I say, I think we're in a strong position to look to how we get that. I think also importantly at that point, it's just to be really clear that A&E performance is not just about the A&E department as we know, it is about the whole system. So I think we can look innovatively at how we might spend that capital should we find ourselves in that position. There's a simple answer to your workforce question, which is no. I think obviously the workforce plan has been written over quite a long period of time actually, and it didn't come out as early as we expected, mainly because there was a negotiation going on around some of the training posts and the numbers in training for the NHS. So ensuring that those were funded was one of the big announcements linked to that, although it's still not entirely clear whether an element of that is an assumed level of productivity improvement. But industrial action continues, and it will be really important for us to get to the other side of that with whatever outcome we need to reach. And I'm particularly concerned, as are all chief execs, about the prospect of having no juniors and having no consultants other than for emergency cover in the next round of strikes. So it's a really important thing to get right. And I think whatever you do, you have to deal with the issue itself, but also the legacy of that. And we need to ensure that we've got a workforce that feel supported and valued, whatever outcome we come to. And I think our chairman has disappeared from the screen, so I'll ask you as vice chair to step in.
Are there any other questions for Glenn? He's back.
Apologies, my house alarm just went off. I apologise again. Any other questions for Glenn? I would just like to say this morning to members of the public, we had a fantastic presentation from a member of staff, Chrissy McElvenna, who was really inspiring with her passion, having joined us and working her way through the nursing side. And Jeanette Hallberg gave a really good presentation with Natalie about some of the things we're doing in terms of nurse recruitment and retention, which was very encouraging. So colleagues, then we'll move on to the estates Q1 report. Robin, Kirsty, over to you.
Thank you, Chair. So I'll hand over to Kirsty on this one, as she's the author of the paper. Kirsty.
Okay, thank you. Good afternoon, everybody. So the paper gives an update on some of the major strategic estate schemes, as well as some information on the site reconfiguration, an update on where we are with our estate strategy, and some schemes that I think are very important as well. So they're included within the paper. So the first one is just to say Community Diagnostic Centre Phase 2 is well underway, almost watertight. And on a good side, we've actually received planning permission for it. So that's always a bonus. We are working on Phase 3 to get that business case ready. and on the shelf if funding becomes available. And we've met with the breast care team and they're happy with the design, so that's going forward in the background. If anybody's been to site recently, they'll notice that the two 30-bedded wards are here. They're on site, and Wernix are busy kitting them out now, which is good news. We're all on plan and we should be finished by the 22nd of December, ready for winter, so that's good news. Just to say, the local planning authority, we have submitted the planning application. They have come back with a number of queries before registering the project. Now, this is a little bit unusual, but in a good way. I think they're trying to avoid any queries coming backwards and forwards all the time. So they've sent us a range of questions which we've sent a response back, and that will now get registered, and hopefully that should cut down the period of waiting for approval for it. Maternity theatre refurbishment is ongoing, still expected to finish in December. It's been quite traumatic, that one. It's an old building, and sometimes when you strip old buildings back, you find things that aren't quite right, but we're on the right track with that now. And we're fully engaged with the clinical teams to deliver another compliant maternity theatre. The ward refurbishment has been going quite well. We've refurbished all of the consulting exam rooms in the antenatal suite, and we've done one bay so far on Drayton Ward. We're a little bit delayed because of a supplier that let us down, unfortunately, so it did prolong that. And we're now pausing and waiting until the baby boom in September is a little bit past, and then we'll continue with the next phase of those works. While we've been doing the works to Drayton and to antenatal, we've also replaced all of the wiring in there. So again, it's just getting that building safer by the day. Mortuary extension as well. We have drawn up a plan for that, and it is due to go into the planning authority again. But we've paused a little bit with that scheme because the ICB are doing a review of mortuary services. So we're continuing to get ready to, as if we were starting, but we're going to wait for the outcome of that review. Obviously, with the CDC, 2 new wards and some other areas, it's an opportunity for the Trust to look at some issues that we've got on site. And I know Robin's been leading a group to look at potential site reconfiguration to address some of our estates-related issues. The estate strategy will be available hopefully for October. I've received the first draft today, so we'll be going through that this week, and I'm sure it'll be going backwards and forwards, but hopefully we'll get that to you in October to the board to sign off. That will be a really good roadmap then for the next 5 years, so we're looking forward to that. And then last but not least, the maternity cafe. So a lot of work has gone on in the maternity cafe on the ground floor in conjunction with the League of Friends. There was quite a lot of work to do in there, and again, when we stripped back the area, it was required a lot more work than we originally thought. We met with the League just before I went on holiday in August, and they're hoping that we should be there or thereabouts towards the end of September to open that cafe. So that will be a welcome addition to maternity and to the other staff on site as well. So that's the basis of this quarter's report. So just if anybody's got any questions, happy to take them.
Really comprehensive. Thank you, Kirsty, and a good session this morning on sustainability. Just conscious of time, quickly, Robin.
Yeah, thank you, Chair. Just to very quickly underline the fact that, just to note, all of this work takes place in an active acute hospital and requires all of the support from all of our staff in order to make this happen and keep these programmes on track. They all accommodate and move around as they need to and work with the estates teams. And so it's a huge effort from all of the teams across the Trust. So just a huge thank you from myself to all of our teams for enabling us to stay on track with these works. And second point very quickly is around the site reconfiguration works. Just to again underline the point that when we put in additional capacity into the site, we need to make sure that we change our operational approach to the way in which we use our capacity, so that we don't just do more of the same and fill that capacity very quickly. So it's right that we take the approach with all of the operational and clinical teams to plan and prepare how we use the whole site in preparation for those new wards coming online.
Thanks, Robin. Julie?
Yes, just very quickly, Kirsty, I went with Catherine over to maternity, and the refurbishment is making a huge difference to the environment for patients and for staff. It's around the reconfiguration work, because we're talking about having the estate strategy in October. How will that reconfiguration work feed into the estate strategy?
We've done some sessions with each directorate, and they raised all of the issues that we're discussing at site reconfiguration. So those issues will all be in that estate strategy. It's just that we might actually get there a bit quicker than we hoped, which is great.
Thank you, Julie. Thank you, Kirsty. And finally, Glenn, then we'll move on.
And I know you just touched on it, Chairman. I was just going to say a little bit more about the focus on carbon reduction as part of our estate strategy that we'll be looking at a little bit later on in the year. We will be making a bid against some of the SALEX funding nationally to move towards net carbon zero, just so members of the public are aware that that's very much part of our focus.
That's super. Thank you, Glenn. Kirsty, thank you for your hard work, and look forward to seeing you soon. So we'll move on then to the Warwickshire North Place Delivery Progress Report. Jenny, what would you like to highlight out of your report?
Yeah, thank you. So just a couple of things really, just that it's a slightly revised style of reporting this time. We're trying a sort of storytelling approach where we're trying to kind of get demonstrate some of the feel of some of the conversations that are happening at place, and also some of the impact that it's having. What you'll notice this time as well is that we feature a particular focus on long-term conditions, because that was one of the focus areas for our delivery group that brought together a range of partners working in that area, and the focus was very much about wiring together work that was happening at place across health, social care and voluntary sector, and also ensuring that that people are exchanging information and making the connections, identifying issues and opportunities to collaborate. So that was a real particular focus this time, which is why we featured it in the report. In Appendix 1, you've then got the high-level updates for some of the key programmes that have had deliverables this month in this reporting period. And there I'd just like to highlight the work that's happened on the winter planning, for example, which Robin and others have been involved in as well. But again, you'll see the integration with linking beyond health in terms of thinking about some of the issues that have been identified through our Health Wash colleagues that we need to take into consideration in terms of our winter planning. And, you know, there's really good integrated work across partners to develop that integrated plan, which Warwickshire North as a place will be overseeing. And then also, because we've got the volunteering piece next, also to note the fact that we're reporting the great work that's happening under the volunteering programme as well, which you'll hear more about in the next report, but just to make that connection, because that links into place partners and a lot of collaboration with our primary care networks in that particular programme. There's others I could pull out, but those would be my highlights, and then you've got obviously the status report across the entire programme in Appendix 2, and I'll leave it there.
Thank you very much, Jenny. Very clear, very comprehensive, and some really great work going on at place. The more as a system, as an ICS, we push into place and prevention, the more effective healthcare will be for the citizens of Warwickshire North. Any questions or perspectives to Jenny? Okay, thank you, Jenny, and thank you for your team. We'll move on then to the 2022 CQC National Urgent and Emergency Care Patient Satisfaction Survey results. Natalie, what would you care to pull out?
It's definitely a mouthful, isn't it, Russell? If I may take the liberty, as we do have Adam, Lorna and Chris joining us today, I'd like to take 8.1 and 8.2 together, because they're both with regards to the urgent and emergency care. So firstly, with regards to the patient satisfaction survey, this is undertaken every 2 years. And I'd just like to say what a celebration it was to receive this, being 5th in the country for our patient satisfaction in urgent and emergency care, particularly during these times. That is not easy to achieve, and I think it's absolute testament to all of the team within ED to have performed so well and to provide our citizens with the service and the quality of care that they quite rightly deserve. But saying that, the team do not rest on their laurels. There are always improvements to be looked at within any of the surveys, and we take very seriously what our patients and their family and carers are telling us and the feedback from that. So I know the team and their actions, and we actually have a co-production open event in September where we've invited members of our community to come into a focus group to talk about what improvement to the services we can bring, what's happening and what they would be looking for, which is all part of our patient experience strategy. Then in April of this year, we had an unannounced CQC inspection. The CQC were in the department for a day and then asked us for lots of evidence, both pre and post that inspection. They were reviewing the 3 domains of safe, responsive and well led, plus a review of the section 29A, which was a warning notice that was given to the emergency department in 2019. The CQC report has highlighted many areas of improvement, including the environment, our governance processes, the really strong leadership that they saw throughout the department, and really key for me was that safe culture where staff were able to and do speak up and take learning from events that have happened. The conclusion of the visit was the removal of the section 29A, and all 3 areas that were reviewed were rated as good, which meant that the overall status of the directorate was moved from requires improvement to good. So on behalf of, if I may take this liberty, on behalf of the trust executives and the board, I'd like to commend the directorate and the team that are with us today for both their results, but also their drive, because I know that they're not stopping at good. They want to achieve outstanding.
Absolutely, Natalie. Really proud of your team. Thank you very, very much for your endeavours and keep pushing. Any questions to Natalie on either 8.1 or 8.2? Please raise a digital hand. Looking forward to the future briefings, Natalie and team. Keep up the great work and be relentless for that improvement. And that moves us, I think, then on to the National Inpatient Satisfaction Survey results. Again, over to you, Natalie.
Yeah. So briefly, an overview of the paper. These satisfaction surveys are undertaken each year. And we have seen a higher than average in areas within the responses, but there's also improvement requirements throughout the report, particularly in our areas of communicating with our patients and their families. There's a big focus at the moment with regards to discharge and how we communicate our discharge plans to both the patients but also to the families. We have a task and finish group that is being run with the frontline teams to try and improve upon this, because the communication is one of the biggest themes that comes out within this survey. We're also preparing, as I said before, to look at our patient experience improvement strategy and really doing the co-production piece. So we're starting with ED and are inviting the public and the community to give us their insight and their feedback about their experiences, but not only that, but taking it forward into how can we make that change for the better. Each directorate receives their own individual responses and particular areas of focus, and we have an improvement plan which is monitored through the patient and carer experience and involvement group and then goes on to our quality assurance committee. So I'm happy to take any questions, Chair.
Great, thank you. And we did have a session this morning with Marie on the work we're doing with dementia patients and their families, which I think is a very important aspect of this area of activity in terms of improving patient experience. Questions and perspectives to Natalie. Julie?
Thanks, Natalie. Just in this, and I think in the UEC one, there are some comments about the need to improve arrangements around food. I wonder if you could expand on that a little bit, please.
Yes, the quality of the food comes up on occasions in both of these, and we know that the place reviews, not to confuse with our community at place, but our place reviews, and what used to be Pete, had been on hold during the pandemic. Those now have restarted. So we are doing those pieces of work, and the inclusion of that co-production is to actually look at the quality of the food delivery, how that delivery is taking place across the organisation. We do a delivery system that means that it's actually served to the patients, which in other organisations it's criticised that doesn't happen. But we also want to review alongside Robin and the team with our menus, because our menus do need an update. It's been some time. To that effect, we have reinstated our nutrition and hydration strategy group and steering group, and we've taken the opportunity, because the ideas and thoughts are coming from our hosts and hostesses. So we have a small shared decision council effect to get our hosts involved so that we can take forward some of those ideas. But continually testing it out and trying the new menus, Julie, is the way forward, and to bring back the actual tasting events through place.
And Natalie, I assume we're getting the patient forum involved in that work, which is great. Just on the subject of menus, Worcester Acute do some interesting work on menu co-production. So either Robin or you to reach out to Sarah or Helen just might be worth joining up the dots there. And Glenn?
Yeah, thank you. I was struck by question 47, actually, asked to give views on quality of care during stay, and just how low that was from an NHS perspective as well as from a trust perspective. And it may be that we do that after the stay, but again, is there an opportunity to work with patient forum or our great volunteers actually to ensure that we do that more as part of the kind of natural habit of how we work in the hospital?
A great point.
Yes, and I think absolutely. I think it's the way the question is asked as well, and how we ask the question of our patients, because we are continually asking for feedback, but they don't necessarily see that as influencing the quality of care.
Okay, great, thank you. We'll move on then to the report on safe nursing and midwifery staffing. Over to you again, Natalie.
Thank you. As already alluded to this morning, the board had a detailed presentation on the work that's taking place with recruitment and retention. So I won't labour those parts that are in the report. Plus, we also went into detail with regards to the reliance on temporary staffing and the plans to reduce that reliance in the future. So therefore, the areas that I'd like to highlight is the continual but gradual reduction in our RM vacancies, but the success of the recruitment in our registered midwives and our healthcare support workers. And we're aiming to replicate that across both our AHPs and our registered nurses. None of the red flag staffing incidents that are reported in the Safe Staffing report resulted in patient harm, and we monitor these very closely, both in adult and maternity, to ensure that any areas where staffing is lower than planned, it does not have a detrimental influence on the care to our patients. Our care hours per patient day remains at the lower end of the national variation range, and we're working hard to improve upon this. And with the recruitment, then we should begin to see this dial moving in Model Hospital and moving us towards the centre and then to the upper quartile. The continued capacity challenges and higher than expected sickness rates have resulted in the continual need for safety reasons in the use of temporary staffing. But again, we are monitoring that and ensuring that all the processes with regards to sickness absence are taking place across the organisation. And we have a daily nursing huddle, where we go through each ward, each department, to ensure that the safe staffing areas are there and that we are alerted to any safety issues. On that note, the daily redeployment remains high. You'll see in the report the number of times that we have to move staff across the organisation to ensure that safety and to ensure that we have our own trust members on each ward. But this must be recognised as one of the highest reasons that staff do express their dissatisfaction. So again, our retention and recruitment are really key to driving this and to improving our staff survey on that factor. I think they're the main key points that I wanted to draw out of the report, Russell.
No, thank you, Natalie. And that last one is key. I'd just like to apologise for staff who do need to be redeployed at short notice. We know it's totally suboptimal. We have got a plan to get the vacancy rate substantially low, which we heard about this morning. So hopefully the cavalry is on its way. But I know it causes a high level of distress being redeployed at the last moment. So thank you very much for your patience. Questions or perspectives to Natalie on the safe nursing and midwifery staffing report? Okay, so Lorraine, it's been a challenging time for all maternity services in many different dimensions. Your maternity assurance update, please.
Thank you, Chair. So I'm going to take the report as read and pick out some main highlights. So this is an assurance report for the month of July 23. So in that month, we had a total of 49 data incidents reported. We had no maternal or neonatal deaths in that month and no serious incidents declared, or we have no open HIP cases either. We've got 21 risks on our risk register and those are all up to date. We've had no stillbirths in July and our rolling rate for stillbirths is 1.39 per thousand births, which is way below the national average of 4.2 per thousand births. Our midwife to birth ratio was down in month at 1:32, but that was because we had a bumper month for births. So the most births I've seen at George Eliot, we had 207 in month. And what was really pleasing to see was 14 of those women that gave birth were not booked with George Eliot. We took them from across the system to support the pressures within our units and outside for areas like Leicester, Northampton, Kettering as well. So really pleasing to see that was also compounded by our sickness and our vacancy rate. Although it's really pleasing to see our trajectory for vacancies. It will be 1.8 vacancies come October when our new qualified midwives start in post. All our women received one-to-one care in labour, and as Natalie said, we didn't have any serious red flag incidents. Really pleasing to see our prompt training is at 93%, which is really great. And our mandatory training is also above 95%, which is really pleasing. And that's for medical staff and midwives and support workers. We're working very hard on our CNST compliance. Year 5 compliance came out in May, so we're working really hard to look at our trajectory at present. We're thinking we're going to come in at 8 out of 10, but we're working really hard on some of those. And we know that Saving Babies Live version 3 came out in June, and potentially with some extra work and audits, we may even get to 9, but I'm not going to say any promises just yet, but we're working really hard on that. As we've discussed, we've got lots of work going on in maternity, so thank you to the estates team, and it's really exciting that the Legal Friends Cafe will be open soon for all our staff. As we've discussed, it is really sad and sickening to hear of the Lucy Letby case. So we've put a lot of support in for our staff. Our sincere condolences and support go out to all the families involved, but we've also been concentrating on our families and staff within George Eliot. So we've written to all our staff, we've got posters and letters for families to say that if they wanted to speak up or share any concerns, and please do. I think, as alluded to previously, the actual learning around freedom to speak up is about all areas. It's not just neonates or maternity. So we have regular freedom to speak up events, we have freedom to speak up training for our staff, and we also have PMAs and PNAs who staff can go to if they've got any concerns. We have really robust governance within maternity and neonates, and it's really pleasing that actually neonates sits within maternity, so they are governed by the same processes. But just to give board assurance, we will be bringing back next month the full report, so you can see of all the governance processes we have in place to make sure that this won't happen at George Eliot. Happy to take any questions, Chair.
Thank you very much, Lorraine. Very clear and very assuring. Any questions or perspectives to Lorraine? Julie?
Thanks, Lorraine. That was really clear. I suppose just to stress, really, I really do feel quite concerned about the negative press, consistent negative press around maternity, but wider now in terms of nursing, because it is much bigger. Yeah. And I think as much support and thanks to them, as Russell alluded to, is really important.
Yes, yeah, worth just emphasising. I think Lorraine's heard me say this before. The oldest nursing profession in history is midwifery. The earliest nurses mentioned in the Bible were 2 midwives who were giving birth to Moses and others, Shiloh and Peor. So midwifery is a wonderful thing to be involved in and a wonderful aspect of nursing. And I can't encourage people enough, considering their options on nursing, to consider midwifery. What a joy it must be to bring life safely into the world day in, day out. But I share your concern, Julie, which is why I think we need to make sure the narrative has balance. Simone?
I think it is a very assuring report, Lorraine, and I think the structures that you've put in place are very robust. The number that does concern me is the 65 overdue incidents, because that's where a lot of the learning is. So can we have that regularly added to the safety briefing data so that it gets raised on a regular basis, please?
Absolutely, and to give you assurance, because obviously I didn't mention, but we do have CQC pending anytime, so that number has come down, and all of those they are ones that just need robustly closing down. There's no harm in those ones, because actually we look at those straight away, and some of those are outside of the directorate. So where we for instance, may put a text in around estates or something like that. It's about making sure that we're working with other directorates to get those closed down. So very much on our forefront, because actually, not just because of CQC coming, but because actually we need to make sure that we are addressing those in a timely manner.
And just 2 quick points from me, just to make sure I understand the Appendix 1. When we have babies born more than the women delivered, is that because of twins or triplets?
Yeah.
Super, I thought that. The other thing is, it's worth just contextualising, I think, a bit how many babies we give birth to safely at the George Eliot. So 207 for us. It's about 270 to 300 at Swift. And I think it's only just over 300 at UHCW. So we do give births, considering the size of us as a trust, to a disproportionate amount of babies, which I think is clearly the choices mothers are making in North Warwickshire as to where they want to give birth. So really well done. Colleagues, happy to move on?
Thank you, Chair.
Thank you, Lorraine. So move on then to mortality and learning from deaths, the Q1 report. Naj, what would you care to pull out?
Thanks, Chair. So I'll just start off with a couple of the metrics. SHME is 107. So SHME measures patients who are admitted to hospital and die either whilst in hospital or within 30 days of discharge. So the figure itself shows that we're still within the national range. And in fact, if you look over the last year or so, it's been gradually coming down. So that's really positive. The other metric that we always look at is HSMR. And again, whilst that's still a bit higher than we want it to be, 111.8, and noted as an outlier, those numbers are also coming down with each reporting period. So again, positive movement and direction. We have been noted as being outliers for sepsis in both SHME and HSMR, and we have got a sepsis working group who have implemented an action plan, and that's reported through mortality and deteriorating patient group. And some of the actions they've implemented so far is distributing 80 handheld devices, which is the means by which patients' observations are noted. And then that gives the trigger for sepsis and obviously treatment, etc. So that's a good bit of work. They're also working on education packages and developing a live sepsis dashboard. And I promised I would also mention the fact that it's Sepsis September. You probably all heard in the media, on the news, etc. And lots of events being organised here at George Eliot. There's a bake-off on Friday if anyone wants some cake. You can come and do a static bike ride on the 15th, I think 15th of September. So loads of events. And it's all to get people focused back on sepsis, how we identify it, how we can treat it early, and get better outcomes. So a lot of credit to the group who are being really proactive. In terms of the deaths, 247 deaths in the quarter, all reviewed by our medical examiners. So that's really good, 100% on that. In addition to that, further scrutiny through our morbidity and mortality meetings to give further, say, assurance of any issues that are occurring in relation to those deaths. Only 9 deaths of, linked to COVID in quarter one, and that's the lowest it's been for 2 years. However, there's a new Pirola virus on the horizon, so it may be that we start to see more admissions with that. And hopefully we've got this vaccine program starting in a week or two's time for high-risk groups and staff, so we can sort of mitigate some of those going forward. And then finally, 5 leader deaths in the quarter. Again, we do a lot of in-depth analysis of any learning death in a learning disability patient or autistic patient, share the learning across both the organisation and at the regional leader group. So that continues to be work in progress. So that's the mortality report in brief. If there's any questions, happy to take them.
Thank you, Nudge. Any questions to Nudge? Just for clarity and okay, after you, Umar.
Sorry, Chair. Thanks, Nat. Just wanted to check in terms of this new kind of variant that you're talking about. What kind of other plans have we got in place just to make sure that we're on the front foot with that? I know there's the vaccine element, but obviously from an emergency planning perspective.
So currently we're in surveillance phase, so it's just to see what's happening. It's been noted in several countries, and I think we're seeing a few cases, nothing severe. So we haven't seen any massive hospital admissions as yet, but clearly that could possibly happen. It's early days in data collection. What we need to do, though, is get this vaccination program up and running. I think that's due to start in another week or so's time, so that we actually are being proactive, that when patients come in terms of actually doing the swabbing and that sort of identification, we haven't got any plans at the moment, but I think that will be guided by Glenn's got his hand up, he's probably got more information, but that will be probably guided by the numbers as we start to see. If they start to go up, then clearly we'll revert back to, as we did in previous COVID phases, of introducing plans on how and when we swab patients, point of admission, etc., and inpatients.
Glenn?
So I put my hand back down, Chairman. I was getting ahead of myself. The question for the next item.
Okay, apologies for Glenn getting too excited. Just on the subject though of COVID, just for clarity now, the 9 who died in the first quarter died with COVID, not necessarily of COVID.
Yeah, absolutely, that's correct.
Okay, which is an important distinction just for members of the public. Okay, thank you, Nudge. We'll move on then, but I do believe the vaccination programme has been pulled forward for the over 60s. So I think I may be alone in this group entering that cohort. So, but it is being accelerated. Trust-wide incidents Q1 report. Again, over to you, Nudge.
Thanks again, Russell. So again, I'll take the paper as read. Again, the paper shows evidence that we have a very good reporting culture in the organisation when you look at the numbers of incidents being reported. Vast majority are categorised low, no harm, which is good. That means that people are reporting before they get to serious harm level. In terms of the categories, pressure ulcers remain the highest reported incident group, followed by administrative processes, which is related to safeguarding procedures, and then followed by falls, medication incidents, treatment and procedures. There's still a lot of learning shared across the directorates at governance meetings. In terms of overdue incidents, again, we're showing continuous improvement in that. In quarter one, it was 299 overdue incidents, and it's 28-day cut-off. So 299 quarter one, which is down from 351 in quarter four. All the directorates have got this on their sort of list to do. They are working to trajectories, and we do monitor them through FPEs. And then finally, just to talk about what's going to be happening over the next few months as we transition from the old serious incident framework to the new PSIRF, Patient Safety Incident Response Framework. Our governance team have been working really hard, both locally and across the system, so some really good collaborative working around the area to transition us to this new PISA framework, and we're all going to do it the same date. 30th of November is the big day when we change over. It's more geared towards learning from incidents. Thematic reviews is a bit more on the agenda there, so a lot of work in progress. And in hand with that is also the way we'll be reporting incidents. So there's two ways we currently do it, something called the NRLS and STICE. That's all going to morph into one LFPSE, learning from patient safety events, which again, it's more learning rather than numbers. So something that we will obviously be monitoring through our own OQSG, QAC, and be reporting up to the board. So at some stage, I think the format of these reports will change. I'm not quite sure what they'll look like, but as we transition over, we'll get a better idea. Happy to take any questions.
Thank you, Naj. Very clear. Questions and perspectives, Glenn?
Yeah, thanks, Naj. It was relating to the 12%, 291 incidents that are related to external sources, as the report says. Could you just give us some assurance about how you handle those when they're not kind of directly within the organisation?
Right, let me just. Yeah, so then what we do is we link up with the organisation. For example, if I give you an example of the ambulance provider, which is a good example. So we share the incidents and we work across what the incident work is, what's happened, the root cause of what's occurred, and then we share the learning. So if there was an incident regarding a handover of a patient, delay, whatever, and an incident's being put in DATEX-wise, we take our learning from it. And we share it internally, and then we share it back with what our output is with the ambulance service. And likewise, if we have raise a DATEX against an ambulance service about an inappropriate patient, we work with them to understand what the incident was. So it's really that sort of communication across the various providers. They are smallish numbers, but we do have them. They do come up frequently, and we do, as I say, some of them extend across to other organisations, other providers such as UHCW, and we do see quite a few across there again. And it's just working with the teams, the clinical teams working with each other to work through the problems.
That's pretty helpful. Yeah.
And finally, Julie, then we'll move on. Julie?
Thanks very much, Chair. I guess for me, as a member of the public, it looks like a lot of incidents. And I think it is really important to think of those in the context of the number of contacts and interactions during that period, and that there's clear criteria for actually recording them. In the future way of reporting, I just wondered, will there be information to compare us with other like trusts, which might be useful as well to gauge that sort of performance against similar trusts?
Thanks, Julie. So that's what we're looking at, how we will be benchmarking in the future. A lot of it is we'll be sharing learning. I think that's more important than absolute numbers. It's going to come out what themes that we're learning rather than this X number of this number of incident. And that's what this system working is happening with UHCW, with the GPs, primary care network, with local authorities, how we share that learning. So I think it's be more about more about the learning rather than, I'd say, numbers.
Glenn, you may be about to make the point I want to make, but you make it first, hopefully.
Yeah, I'd rather see a high level of reporting of low-level incidents, actually, which kind of indicate that we've got a good reporting culture and that we're taking opportunities to learn. So I think sometimes when you look at benchmarking, people can be misled into thinking low is good when it may well not be.
Yeah, and just building on that point, I want to make a general point because we touched on it slightly when we were talking the midwifery assurance report, which is about the freedom to speak up. Freedom to speak up and whistleblowing or talking about an anxiety or talking about something we need to learn from is part of a healthy, vibrant, open culture. I'm not as worried about the numbers. I'm more worried about the culture. Unfortunately, healthcare is inherently a very challenging area to operate in, and occasionally mistakes are made. The key thing is that we speak up, we recognise it and we talk about it. And at that point, perfect timing. Nazani comes on screen, but we'll come back to you in a wee while. Anything else, colleagues, before we move on? Okay, thank you, Naj. So we'll move on then to the integrated performance report. Catherine, do you want to give us your summary, please?
Thanks, Russell. So the data we're looking at in this month's report comes from July. And usually, as you know, I like to start with the operational performance and tell you how that's impacting on the finances. But this way, I'm going to switch things around a bit and start with our financial picture and then explain why we are where we are and what steps we're taking in order to address that. So as we all know, we set ourselves a challenging and ambitious target around cost and productivity improvement in order to achieve a break-even position by the end of the financial year. And this was built on two main areas where we felt we had our biggest opportunity, which was around delivering 118% of the activity we delivered in 2019-20 and significantly reducing our reliance on temporary staffing. Unfortunately, I am reporting that we aren't making the progress that we need to see in either of those areas at the end of month 4. And that consequently led us to a deficit of £4.5 million at the end of July, which is off plan by £2.35 million year to date. 1.8 million of which is due to an underachievement of our cost and productivity plan. So let's look at the underlying factors in turn. First, the elective recovery performance. Now, this is a little bit of a mixed picture. Although in July we delivered more elective activity than pre-COVID levels, especially in terms of inpatient elective work, from a financial position, we did not deliver as much as we planned to deliver, and the case mix of the activity we did was of a lower financial value, predominantly driven by a lower number of orthopaedic operations than in our plan. From a performance perspective, we continue to achieve no patients waiting over 78 weeks and have a very small number of patients over 65 weeks. And we continue to forecast that we will meet the national ambition of having no patients waiting over 65 weeks by March 2024. The RTT position dropped slightly in month to 65.1%, but compared to the national figure of 59%, we are continuing to fare better than many of our peers. The ambition is to eliminate 52-week waiters by March 24 and exceed the national aim. Given the uncertainties around industrial action and the challenges of winters and other factors, it's hard to predict with confidence that we'll meet that ambition, but aiming for that is the right thing to do for patients, and we'll continue to press for that. I also would like to make the board aware that due to the ward closures in August to allow for construction of the 2 new wards for winter, that had an impact on our bed capacity, and we're forecasting a further deterioration of the position in August around many of our performance metrics, including the ERF income and elective activity. Work has already been commenced by the directorate teams, well commenced, in order to work on recovery actions to increase the elective work and the first appointments in outpatients during September and October. So we're trying to recover the activity that was forecast in the original plan. As well as supporting the financial position, that will allow us to treat more patients and support the delivery of the elimination of 52-week breaches by March 23. The operational financial teams are in the process of refreshing the plans, and by the end of this month, we should be in a better position to forecast the year-end position in respect of elective recovery. The other driver of our cost and productivity underperformance is around temporary staffing. As Natalie's already mentioned, we spent a considerable time this morning looking at the progress that's been made on nurse retention and recruitment. And whilst that's an extremely positive story, the impact of this will be felt later than planned for our financial plan, and coupled with things like the high level of bed occupancy that has not allowed us to close surge areas, for the higher than forecast sickness levels and industrial action, we don't believe it will be possible to achieve all of the temporary staffing CPIP by the end of this financial year. Ways of offsetting that through other schemes are being actively progressed, and you will see in Hack's narrative in the IPR section the additional steps on temporary staffing that are being taken in order to reduce those costs. If I could now turn to our other performance metrics, our ED team, most of whom are still on the call. Our challenges around bed occupancy continue to make flow through the hospital difficult, and that impacts on our emergency performance metrics. Our ED standard fell in July slightly to 75.4, and that's below the national standard of 76% but it's below where we want to be. This will deteriorate further in August due to the bed closures for the new wards. And we saw a rise in July of ambulance delays over the air to 2.1% of our ambulance attendances. And whilst that's low by comparison to many others, which should be a concern to us all, that emergency performance remains so challenging during our summer months. In June, the Cancer 28 diagnostic standard improved to 70% in line with our improvement trajectory. The 31 days from cancer diagnosis to treatment performance remains good at 98.5% and much better than the national average at the moment of 91%. The number of patients waiting over 62 days for treatment remains challenging, and although that number fell slightly in month to 59, this continues to be of concern to us. I do want to say at this point that the impact of consultant industrial action impacts much more significantly on cancer activity than we've seen through the junior doctor industrial action to date. That is because cancer care is predominantly delivered by senior clinicians, and whilst we try as hard as possible to preserve our cancer activity during periods of industrial action, it is hard to deliver operations, clinics and multidisciplinary team meetings. And I would advise that this position may deteriorate further as we go on through the year if we continue to see industrial action. On quality, Naj has already mentioned the improvement in the mortality indicators, and that seems to be being sustained, which is really pleasing to see. He's already told you about sepsis September, so I won't talk any more about that. Our statutory and mandatory training rates remain high, but we failed to make the same progress in terms of our appraisal rates, and that continues to be an area that we have got to address in order to make sure that we are supporting and valuing our staff. And in the nursing quality metrics, Natalie's report draws our attention to the ongoing work around infection prevention control team in order to make sure that we have low numbers of hospital-acquired infection. Lastly, Russell, I want to draw the board's attention to something which is not measured in the IPR, but as we've talked a number of times, is very important to us. Through our staff survey last year, we identified the need to increase our staff's confidence around speaking up. In June, we made the decision to ask all of our staff to complete the National Freedom to Speak Up training and all managers to complete the Listen Up training to support them to take the right action when staff do speak up. To date, we've trained 53% of our staff and 58% of manager, and we're really working hard to increase that number. As a board, along with senior leaders, we've all committed to doing the follow-up training so that we also can look for the signs where there may be problems and know how to take the right action. In light of the crimes committed by Lucy Letby in Chester, it's absolutely right that we create the right conditions for staff to be able to raise concerns and for those in a leadership position to be able to support those who do. It's our responsibility as a board to create a culture of honesty and openness where staff know they will be thanked for speaking up and have confidence that we will listen and act on their concerns. As we've already touched on Glenn's report and in the maternity assurance report, a constant inquiring mind into what our data, our staff and our patients are telling us across all of our services is at the heart of how we work now and how we will continue to act. So in summary, our teams are dealing with some very difficult issues. The position in August is likely to deteriorate before it gets better, but that in part is due to us doing the right things in terms of making the right decisions around our capacity with the new wards for the winter months. The actions we are focused on as a team are the right ones for patients. And I'd like to thank every member of the team for their continued drive for improvement, hard work, and their patient-centred approach during these sustained challenges which is affecting the whole of the NHS. The resilience of our staff continues to amaze me, and we must not take that for granted. Thanks, Russell.
Thank you, Catherine. Excellent summary, the start of which puts you in line for a potential job as a Chief Finance Officer, which surprises me. Hack will be being worried about the elucid way you describe the financial situation. And Deepa's going to cover off the freedom to speak up, but I fully endorse what you said at the end. And I think the other thing is we have to go through this short-term pain, performance pain, to put in more capacity for the medium term for the citizens we serve. It will serve them best if we do so. So questions or perspectives to Catherine? Any questions on, you know, FRS, any other accounting details? She may do a segue to Hack, but otherwise questions or perspectives to Catherine? Simone?
It's on the freedom to speak up issue. So quite rightly, all the focus is on enabling our staff to speak up safely. But a lot of what happened in the Letby case and in previous NHS investigations is about patients not feeling that they're listened to properly. Should we be thinking about some more formal mechanisms to enable our patients to speak up?
So I think the answer to the question, Simone, is that one thing is not enough. This is about a culture of looking through, triangulating all of the information that is available to us, whether that's mortality rates, patient complaints, patient feedback, like some of the surveys that we've looked at through, encouraging staff to speak up. Freedom to speak up is not just about staff, it is about listening to families as well. Many of us will have heard the news yesterday with the sad case of the family that lost their daughter to sepsis. We've just heard a talk from Melissa Mead, who lost her son William to sepsis, and both of those cases are about families that didn't feel heard when they were raising concerns. So the culture that we have to create as a board and in our teams and throughout this organisation is about looking inquiringly wherever that information comes, whether it's from patients, from staff, from the data, from outside our organisation looking into it. That is what is going to keep patients safe for Nuneaton and North Warwickshire.
Well said, Catherine. Thank you. Any other questions to Catherine? Paul?
Yeah, I note in the papers, Catherine, Hack, that with the national rebasing and the reduction from 109 to 107%, that the 2% will be held and distributed at ICB level. Are we confident that we'll get a proportionate part of that sum? Have we got any insight to how that will be distributed? I know it says to be agreed, but I do wonder whether those funds will be directed to the larger partners in the sector.
I'm going to defer to Hack, who has his hand up, who's going to attempt to answer that question.
Right, so it's not been formally agreed, but initial kind of indications were that we stay as is because of that budget is already been allocated out to us, so it's in our plans already. So that we don't change from that position. So that's the initial stance at the moment. It hasn't formally been agreed yet in our systems.
Okay, thank you, Hack. And so watch this space. Robin?
Yeah, just to underline the points made around the operational performance and the expected dip in August is obviously not something that we want to just sit back and accept. So what we are doing to counteract that is emphasising through September, October, as Catherine alluded to, supersizing our efforts in order to place catch up and provide those vital clinical services to our patients and local population. And we're linking in with the Further Faster national work stream that some of us will go onto a meeting about later this afternoon, where we will be able to update on our plans, which involve providing a couple of Super Saturday outpatient clinics where we'll see over 100 patients per clinic on those days. And also the teams are working on a super joint week, as they're calling it, which is looking at getting over 40 joint procedures through theatres at George Eliot within 1 week. And that will attempt to play catch up on some of that work we lose through August, as we've said in a planned way.
Brilliant, Robin. Can you let me know those dates?
Will do.
Because, you know, what I do want to ensure is as we end this financial year, our run rate is at a great, you know, significantly improved level. Finally, Glenn, then we'll move on.
Yeah, it's just picking up on the theme of trying to ensure that we do sustain our sustained level of improvement and therefore stay in segment 2 or better in the future. The Cancer 62-day performance, this is probably one for Robin. We highlight within that some poorer performance on some of the tertiary pathways. Now, is that because they are complex pathways, or are there some other things that we need to tackle there?
Predominantly because they're complex pathways. There are some delays in some of the pathways that we've seen exacerbated by the recent industrial action and the impact of tertiary centres and tertiary providers on their element of service, which obviously causes delays in the total pathway. So there's a multitude of factors that we are working through to ensure that we maintain and improve performance in those areas.
Yeah, I've always felt it's somewhat unfair for the performance of our tertiary partners to be included in our performance measure, which affects our rating. That doesn't seem particularly just. Robin, then we'll move on because we're running.
Yeah, I think the one sort of caveat to that is if we can improve our performance, particularly through the development of the CDC expansion in phase 2, as was mentioned earlier, in order to get those referrals to tertiary providers within 38 days of their pathway, then actually that doesn't become part of our performance metric. So that needs to be our aim, to expedite that first section of a patient's pathway, which obviously ultimately is better for the patient.
That's super, thank you. And Deepa, then we'll move on.
Thanks, Russell. It was just in relation to the point on theatres and performance, and particularly Super Joint Week. You'll know that concerns have come through theatres regarding workload pressures and well-being. I just wanted to know if there's any assurances that you can give regarding supporting that to ensure that that doesn't have any negative impacts.
Thank you, Deepa. Robin?
Yeah, one of the key areas that we're focusing on is actually the engagement with the staff through the setup in that period. So we're using it as an opportunity, Deepa, to pull together the feedback from the recent survey that was done amongst the staff, how we empower the staff and how we set some targets during that time. That also means that, for example, one of the targets we're looking at is making sure that staff all go home on time during that week, and managing some of the concerns that they've had. So yeah, absolutely fundamental to that work going forward.
Thank you.
Thank you, Deepa, but keep monitoring it for us and let us know if people's anxieties, colleagues' anxieties are on the leave. Okay, Tim, we'll move on then to the summary of ratified policies. What would you like to tell us about here, Catherine? Catherine?
Sorry, I was just writing something to Deepa in the chat box, but forgot I still had a job to do. So, Russell, this is a quick one. The last one was a long one. There have been 4 policies ratified. The list of them is on the document there. I don't have anything further to add.
Thank you, Catherine. I'm now intrigued as to what you're writing to Deepa. Any questions?
Just to reassure her, I'll say it, that we really have taken those concerns seriously. And as Robin says, those have been factored into the planning so that one of the outcomes is staff getting home on time, staff feeling safe, staff feeling able to raise any concerns, and they're involved in the design of that week rather than things happening to them. So I just wanted to reassure you on that.
No, thank you. Any questions, Catherine, on the ratified policies? Well, that segues quite nicely deeper into your updates. So the 6 monthly report, please, on freedom to speak up.
Thanks, Russell. So I shan't go into too much detail in respect of the report, taking most of that as read. I will mention a few highlights. But to begin with, I think it would obviously be remiss of me not to mention the Lucy Letby case, and I'm sure that you've had lots of discussions around this already prior to me joining. But just to emphasise that the report that's within the papers was obviously prepared and submitted prior to the judgment in that case. And you'll all be aware that this was a situation where consultants and staff were raising concerns but weren't listened to. And in fact, they were threatened and silenced. But it is just worth me saying that those offences occurred prior to the Freedom to Speak Up Guardian role being in place. And so we'd all like to think now, with the processes that we do have and the National Guardian's Office and the Speak Up role, that this could and would never happen again. But this does bring to the fore the importance of ensuring that everybody feels safe to speak up, and when they do, that they will be listened to and appropriate action and feedback will follow. One of the key actions, as Catherine has mentioned, this year has been the rollout of the Freedom to Speak Up training. So that's the Speak Up, Listen Up and Follow Up training. And we've really shown our commitment as an organisation to creating a safe speak up culture. And currently the figures, as Catherine said, stand at approximately 53% of staff. So I think we're doing really well on that front. We also delivered the follow-up training to the senior leaders last month. And of course, they're responsible for setting the tone and role modelling that positive speak up behaviour and creating that safe culture for everyone to be able to raise concerns. We've also had some discussions only yesterday with our governance colleagues around triangulation of data and knowing when somebody is actually speaking up so that you can respond and act appropriately when that happens, because of course speaking up happens at all levels and in all parts of the organisation, not just via the Freedom to Speak Up route. So just going back to some salient points in the report, civility training has continued during this period, the basic awareness session, as well as the manager's toolkit on tackling incivility. And we know that attitudes, behaviours, bullying and harassment continue to be concerns that are raised quite frequently through our routes and through people and workforce as well. So it's really important that that awareness continues. We've also been part of some peer review visits to wards and departments with the Compliance and Regulation Officer during this period, and some deep dive work has taken place within theatres and the Women and Children Directorates too. Positively, we've recruited a further 6 Speak Up and Wellbeing ambassadors across ED, pharmacy, paediatrics, maternity and people development. So we now have 12 ambassadors across George Eliot, and we'd like to continue that recruitment and promoting of that role so that we can continue to further the Speak Up and Wellbeing agendas. We are in the process of expanding the Speak Up team and recruiting an admin and project officer, which will enhance the work that we do across the organisation as well. During this period, we've had 47 new contacts between February and July. Again, that might sound a lot, but I would just echo the point made by Glenn earlier that lots of concerns being raised is not necessarily a bad thing. It's good when people are raising concerns and they're able to do that, even if it is via the Speak Up route. But of course, we know that that happens elsewhere and that we need to respond appropriately. The main themes that have come out of the concerns, as I said, are around wellbeing, attitudes, behaviours and bullying and harassment. Of the 47 cases, 16 directly cited bullying and harassment. So in those cases, appropriate support is given from a pastoral perspective. As far as we're concerned, signposting takes place, whether that be to mediation services, facilitated conversations, more informal interventions or formal processes via people and workforce as well. Happy to take questions.
That's great, Deepa. Questions or perspectives to Deepa. We are running a bit late, guys, so if we could be to the point, Paul.
I suppose a little concerning that over a third of the reported cases relate to, allegations, I guess, or poor behaviour, bullying, etc. Have we got other ways of keeping tabs on that other than people raising concerns through this? So, I mean, are these issues that are picked up in staff surveys? Because at the moment, it'd be useful to know whether this is a thematic issue or maybe isolated for some of the reasons you've given.
Yes, it's picked up through staff survey. It's picked up through the department and directorate management channels as well locally. It's picked up through the people and workforce teams as well, and wellbeing. So through Datix as well, because concerns are often logged as incidents through there concerning bullying and harassment too.
Deepa, your answer was so comprehensive that Catherine put her hand down. Glenn?
Yeah, as you quite rightly pointed out, the Lucy Letby case happened before Freedom Speak Up Guardians were introduced, and you together with Sue do such a fantastic job within the organisation to be that person that people can go to raise concerns. One of the things that's come out, that I always worry that we introduce another set of things before we actually work out why the existing arrangements are not necessarily working everywhere. I very much value the meetings that we have where you keep me and the team up to speed with what's going on in the organisation. And I think there's some people are suggesting, though, that maybe that should be externalised because reporting into the chief exec in an organisation may compromise your ability to raise issues. But my view, and I'm sorry I should have given you warning of this question, my view is that because you're inside the organisation, you hear more, know more, and understand the culture more, and therefore can have your finger on the pulse more of those issues. And there's an awful lot which you help us to tackle at a very early stage before it becomes something of any major concern. So I suppose it's just your perspective on that balance between the independence of something outside the organisation versus the day-to-day knowledge of being inside the organisation.
My response to that, Glenn, is I think there's pros and cons of actually both, and I really personally appreciate and value being part of the organisation and being able to raise those concerns internally, and having that role embedded within the organisation, but still feeling able to be impartial and challenge where necessary. I know from the regional perspective that there are contradictory views to that, and I think it really depends on the support that you get as a Guardian, as a Freedom to Speak Up team, in terms of furthering what you're doing and what you're trying to achieve and the improvements that you're trying to make. So yeah, that would be my response to that.
So on that last point, Deepa, is there any more support you would want to be getting from the board?
I think not necessarily from the board, but a collective push and regular reminder about the importance of speaking up and that positive response when people do speak up, because there is certainly an increased feeling of futility amongst staff when they raise concerns, and that's something that I think we should all seek to try and overcome.
Okay, well, I know Catherine Moore is on that, so just continues to keep us brief, because we don't want people to feel it's futile to speak up. And just in terms of you, are you still enjoying the gig, or are you fed up with it?
Yeah, I'm still happy, Russell. Thank you.
You take care. Thank you for your hard work.
Thank you.
Thank you. So just keeping things moving, guys. We are running a little bit late. Samara, lovely. I know you can join us today. What would you care to pull out of the Controlled Drug Accountable Officer report for 22-23?
So basically, the report has already been to QAC and OPQSG as well, so it's had the scrutiny from those committees and groups. This really covers my assurance for the trust around what's been happening with controlled drug governance and management across the trust. and really gives us an account of the different measures we are using to ensure that we have appropriate governance and oversight in place. And along with that, I would also like to emphasise that support that we are putting in place for our teams to ensure there's iterative learning going on for us as well. There was no issues of concern. All the investigation and incidents that were picked up were reviewed independently by me, as well as MSO, and by the divisions and the area managers. There was nothing that we really reported externally either as a concern from the organisation. I think we are on a continuous improvement journey. I won't say we're 100% there, but we have good systems in place. We've got good policies and governance in place. And one of the positive things as a CDO perspective is that we are actually having a lot more engagement as MDT around how we address some of the issues and how we work together. So that's the focus for me of the next year, is how we improve some of the concerns that we've still got outstanding, which are often around our audits and compliance to audits, because they are very much yes, no legal standard questions. And our audit standards are very high, around 90% pass rate for each area. So even if, you know, when I look at my regs every month, there is an improvement through that journey as well. We are not definitely hitting 100% in all areas, but there is work ongoing to support those. So over the course of last year, I would say that I've been assured around the processes, no concerns. Just talking about escalations and just hearing what people were saying earlier, I think one of the things I probably haven't reflected in our report either is, from my perspective as a CDO, obviously as a statutory role, I do report externally to NHS England, but internally as well, that any concerns that I have direct access to Glenn, and I do a regular reporting as CDO to Glenn. So I'm able to raise any concerns that I have, or any support I need directly with Glenn, as well as our other exec leads as well. And there's been no real concerns from us this year. So that's probably the summary from me at this stage.
Super, thank you, Samara. Very clear and very helpful, and thank you for your hard work. I know for all of our pharmacy colleagues, it's been a very, very busy year, and there aren't enough pharmacists in the country. Questions or perspectives to Samara? Okay, super. Samara, take care. Look forward to seeing you soon. And we'll move on then to the Adult and Children's Annual Safeguarding Report. Over to you, Natalie.
Thank you, Chair. Firstly, I'd like to thank our safeguarding lead and our clinical leads for the work that have gone into this annual report and the overview, and to draw out a few pertinent points. Is to state that our teams have met all of our statutory obligations, and we're working alongside Warwickshire Safeguarding Partnership, raising the awareness and ensuring that we have that collaboration in process and working well together. The cessation of the Liberty Protection Safeguard was a welcome to us from Parliament because of the uncertainty with regards to the resource and capacity, which does mean we now have the ability to strengthen our MCA and DOLS processes and update our current practice and policy to reflect that change in direction. You'll note from the report that the complexities of referrals, particularly in maternity and children's, have increased over the last year, and these are monitored very closely, both internally and externally through the partnership, to ensure that we are capturing what we need to capture and make sure that we have any themes and trends. We also have a very robust safeguarding assurance committee where we take case studies from adults, children's and maternity at each meeting, so that we can extrapolate the learning from any of the cases that we hear. And then finally, our training, you will note in the paper and report, with the exception of level 3, we have hit and exceeded the 85% target, and we have and are on track to ensure that our level 3 safeguarding will have achieved the 85% and above before the end of the 23-24 period.
Natalie, very clear. Thank you very much. Any questions to Natalie on the annual safeguarding report? Keep up the great work, Natalie. And we'll move on then to the IPC annual report. What would you care to pull out here?
So I'll again try and be brief and thank our IPC teams for pulling this together. It's a very comprehensive report of the year. We did and were still managing the controls around the COVID pandemic and changing towards that being business as usual and aiming for the good prevention and control practices across infection prevention and all health associated infections. We've been set a very challenging target from a national perspective in regards to all of our HAIs, and this is against a backdrop of increasing community infections, which is shown in Table 1. That being said, we have a very comprehensive improvement plan, and we're working together with our pharmacists, antimicrobial stewardship and microbiology through the SLA to ensure that that improvement trajectory and plan is on track. But also we're working alongside the ICB because, as I noted and stated before, the community infections are on the rise as well. So it is in parallel that we're working on an improvement plan towards that. We are reviewing our microbiology SLA and trying to improve on the stewardship that I've aforementioned, and Naj and I are working alongside with Robin to review that SLA into the future to ensure that it's fit for purpose for the George Eliot.
Thank you, Natalie. Any questions to Natalie on the IPC annual report? Love the picture of the team with the backdrop of back to basics, absolutely. Okay, team, we'll move on then to subcommittee chairs updates. The first is the Quality Assurance Committee for the 27th of June, 25th of July and the 22nd of August. Sarah, anything you would like to emphasise or pull out, particularly with respect to the 22nd of August?
So really just to say I'm delighted that we've got some new associate non-exec directors, because as you'll know, a couple of our meetings were not quorate, so that will really help us with our quoracy. Just to give committee assurance that we do delve into appropriate detail into a lot of the things that then come through to board. So please take some assurance from that. In August, we obviously focused looked at thinking about the Letby case and how we would assure ourselves that we've got appropriate oversight in our quality committee. We are continuing to work and there will be progress, and please do hold the committee to this, that we're working on consideration that at the moment we report a narrative assurance to you, and whether there are different ways we could do that. No conclusions been reached, but we are progressing that, so please do hold it. I think I've written in my report for the last 3 months that we are progressing this, so don't be satisfied if you see that again next month, please, Chair.
Okay, thank you very much, Sarah. Questions or perspectives to Sarah? Okie dokie, so we'll move on then to the Audit Committee, the Extraordinary Audit Committee of the 18th of July. Simone, anything you particularly like to pull out?
Just 2 things, please, Chair. One is I just wanted to point to the substantial opinion that we've received from internal audit after their review of maternity services. Just added that extra level of assurance that I think we're all seeking in these times. And secondly, the unmodified audit opinion that's been issued by Deloitte following the completion of the year-end processes. Both bits of good news, I think.
Great, thank you, Simone. Any questions to Simone? Okay, the Quality Assurance Committee then, minutes of the 27th of June and 25th of July, I will take as read. Any questions on either of those? Can't see any hands up. The Audit Committee of the 16th of May and the 19th of June. Any questions or perspectives on those? Okay, super, thank you. So I think then we're on to any other business. Any other business, team? Please raise a digital hand. I need to apologise. There was another declaration of interest I needed to make, which is I'm the owner of a new company called Maranatha One Properties Limited. It's already a declaration that I'm the owner of Maranatha One Limited, but I'm also the owner of Maranatha One Properties Limited. So we'll move on then to questions from members of the public. Sarah, have we had some questions? I know we have, but hopefully we've addressed some of them as we've gone along. Sarah?
Yeah, we had a question from Natalie and David from the Patient Forum. In view of the tragic happenings of the Countess of Chester Hospital, can you assure the people in our area that you have safeguards in place to prevent this happening at George Eliot? And how do you protect those that speak up about a concern? And I know that has been addressed through a number of agenda items today. I don't know if anybody wants to add anything. Thank you.
Well, can I just go back to Natalie? Natalie, are you happy with what you've heard in terms of assurance?
Yes, I am. But just when you talk about the freedom to speak up guardians, are these in all disciplines across the Elliot, or are they in directorates? I mean, do all levels of staff have somebody they can go to? How does it work? Because I think sometimes if you're not so senior, it's quite difficult to speak to somebody that's more senior.
Great, thank you, Natalie. Catherine, do you want to come in on that? And then I'll just ask Deepa for her perspective. Catherine?
If Deepa's still here, or Deepa could answer the question for us, Deepa. I wasn't sure you were still here. I'll let Deepa do it.
Deepa, you're on mute.
Apologies. Hello, Natalie. The Freedom to Speak Up Guardian role is across the organisation. So anybody, any staff member at any level within the organisation can come to the Freedom to Speak Up team to raise a concern, whether that be openly, confidentially, or even anonymously. And within the teams, within some teams, there are also Speak Up ambassadors who will not case handle, but will be there to hear concerns and then signpost to the relevant support or department or person that needs to go to for further support or intervention. I hope that answers your question.
Yes, thank you. So if you were working, say, in the portering team, would be an ambassador within that team, or would it be within the directorate? That's what I'm trying to get at. Would it come across rather than up?
I see. So yes, so people can raise concerns with their peers. If there isn't an ambassador within their team, they can speak to an ambassador in any other team. But equally, they can come to Freedom to Speak Up as well as an alternative route. So they don't have to go to escalate to management, if that's your question.
Yeah.
And Glenn, do you want to come in? Because I just wanted to add some colour, but you go first.
Yeah, just in addition to that, we do something which not a lot of trusts do, but we now do this across the group, which is we have what's called the rumour mill, which is a intranet portal where staff can anonymously post any questions or issues that we then respond to and post there for all staff to see. And we always test that it is anonymous and it is quite well used to staff, and it gives us good insight into some of the other concerns. But anything that's more clinically focused, we would always encourage staff to talk directly to Freedom to Speak Up or through their clinical managers.
Thank you.
I think also, Natalie, although we can be assured, we shouldn't be naive. And, you know, but fortunately, in the history of the NHS, there have been very few situations arise of this type of very ill, evil people working in a position of care. So it does happen very rarely, and all members of colleagues need to support one another, but equally recognise when things aren't working out. And it's why, for example, not just Deepa's role, but the way NADG looks at mortality rates is very important, and the metrics we show up on that. So it's an issue of triangulation. But thank you for the question. Sarah, were there any others? Otherwise, David's got his hand up and I'll go straight to David.
No.
David, your hand was up.
Thank you, Chair. 2 points, if I may. One is, as a member of the Patients Forum, it's a point of clarification, if I may. Earlier in the meeting, there was perhaps a feeling that the Patient Forum at the George Eliot is part of the management, and the Patient Forum at the George Eliot is a totally independent volunteer group. We do undertake work on behalf of the Trust from time to time, but essentially we are the eyes, the ears and the voice of the patient, and we are a critical friend. So that's on behalf of the forum. And just not as a member of the forum, Chair, but as a concerned person, Freedom to Speak Up, the George Eliot, for many years has been at the cutting edge of developing this as a programme within the staff. This goes back to a previous director we had who was passionate about moving away from whistleblowing to the Freedom to Speak Up programme. And I think we've been enormously successful in that area. My thinking, Chair, is that do we know, can we establish if the staff members would feel more inclined to speak to someone from the Freedom to Speak Up team who is independent, not on the payroll of the NHS. I'm thinking mainly of the police experience where they were unsuccessful with their own monitoring until an independent review body was established. And I just wonder if there's a place for the National Health Service, and the George Eliot could pioneer it, to have a trained independent person as a member of Freedom to Speak Up. That's my soapbox. Thank you, Chair.
Okay, thank you, Dave. Just on your first point, I'd just like to emphasise how grateful we are for the input of the Patient Forum in a whole range of work over many, many years. And you being the voice of patients, if you like, really does help us make better decisions. So it was in that regard that the comments were made earlier. I think on the second one, as Deepa indicated, there are pluses and minuses. And it's where I would emphasise the import of the rumour mill, because some people won't, which is a shame, but arguably life being life, understandable. Some people will be fearful of putting their head above the parapet. The rumour mill is a totally anonymous way, though, of making any anxieties known at the most senior level into the executive directors. So as Deepa said, you know, we will continue to assess the advantage of someone external. But even if it were someone external, you've got to make that step, that phone call, that knock on the door and say, hello, my name's Russell Hardy. I'm concerned about this. The great thing about the rumour mill is it's totally anonymous, which I think is deeply powerful if there are any anxieties. Deepa, is there anything you'd like to add to my answer?
No, Russell, I think that covers it. Thank you.
Glenn?
I think just to add, there's also the CQC, there's also Royal Colleges. There are a number of different ways that individuals can raise concerns in addition to those that we have within the organisation.
And Jane has asked in the chat box, but if anonymous via rumour mill, how does the person raising the concern know the outcome or what is done? Glenn, can you just explain for a second the way the rumour mill works?
Yeah, so the approach is that every question goes to the relevant exec, ideally, but also leads get involved in this, and we put the question and the answer there on the rumour mill for all staff to see. So it's not just held for that individual. So it gives everyone a sense of what's out there and what the response to it is.
Yeah. Which is incredibly open. David, your hand is still up. Is that legacy, or are you happy to take your hand down?
No, it's just a point, Chair, if I may. I'm pretty sure that our chairman of the Patients Forum would be more than happy if we undertook some drilling down with your staff as to how they see the Freedom to Speak Up function. Thank you.
Okay, well, thank you for that offer, David. We'll reflect on that. Thank you. Okay, well, lovely to see you all. Our next board meeting is on the 3rd of October. Julie will be chairing that on my behalf. Thank you, Julie. And I look forward to seeing the rest of my colleagues in the confidential session at 4 o'clock. So time to grab a quick coffee. Thank you, everyone, for your hard work. Lovely to see so many people on the call today. And take care. Bye-bye.
Thank you.